Good evening, everyone. I am Dr. David Yeager, Chair of the Educational Committee of the American Society of Podiatric Surgeons, and I will be your moderator this evening. I'd like to welcome you to the live webinar on Why the Thigh, How Thigh-Applied Intermittent Pneumatic Compression Can Improve Healing to Lower Extremity Wounds, sponsored by Huntley this evening and the American Society of Podiatric Surgeons. Next slide, please. Thank you for joining us this evening. If you're not a member, I strongly encourage you to join. There is our webpage. Next slide. And I'd also like to formally invite you to our annual conference this year in New Orleans. It is next week. There is please visit our webpage to register. I think that you're going to get a lot of great information. We also have on demand too that's going to be available as well. So further encourage you to join our association and encourage you to actually really understand what we're all about, and that is really surgical education. So our learning objective this evening is Why the Thigh, How Thigh-Applied Pneumatic Compression Improve Healing to Lower Extremity Wounds. So really, what are you going to get from this? Well, describe the response of the arterial and venous blood flow during the rest phase after thigh compression. Identify the 4 clinical findings of phlebolymphedema, and understand the 2 clinical reimbursement CMS pathways for intermittent pneumatic compression. Next slide. Accreditation. This live activity and online enduring materials are accredited by the American Society of Podiatric Surgeons, or ASPS. ASPS is approved by the Council of Podiatric Medical Education as a provider of continuing education in podiatric medicine, and approved this activity for a maximum of 1 continuing education contact hour. Completion of the post-event evaluation survey is required to receive credit. Attendees completing at least 1 hour will receive a survey link immediately following this program. Next slide. Question and answer instructions. I strongly urge everyone that's involved to get involved in the Q&A. Please use the questions area located in your control panel for any inquiries during the presentation itself. I will monitor the Q&A session after the presentations, and I'll be writing them down and we can go over them together. And please, if you'd like to direct it to a specific speaker, please identify that person as well. As I alluded to at the beginning of this short presentation at the beginning, I would like to strongly encourage you to visit Huntley's webpage and Arjo. Without their gracious sponsorship, we would not be able to provide this incredible presentation this evening. So without further ado, let's get started. We have 3 amazing lecturers on tap this evening for you, and they'll be discussing why the thigh, how thigh-applied intermediate pneumatic compression can improve healing to lower extremity wounds. I want to personally thank Huntley, a member of the Arjo family. We are going to discuss Wound Express. Our first presenter on your left side of your screen is Dr. Alton Johnson. He's a clinical professor of orthopedic surgery at the University of Michigan Medical School, specializing in podiatric surgery. He graduated from Kent State University of Podiatric Medicine. His residency was in HCA Florida Adventure Hospital. He completed a fellowship in podiatric research and wound care at Penn University. He's board certified in podiatric medicine by the American Board of Podiatric Medicine. He's board certified by wound care specialist by the American Board of Wound Management. He's a board member of the Kent State University Podiatric Medical School, and he's chairperson of ASPS. Our second presenter is Dr. Traci Kimball. Dr. Kimball is board certified in wound management, specialist physician with additional qualifications in undersea and hyperbaric medicine, vascular medicine, geriatrics, and surgery. She has a passionate focus on the quality and delivery of care to patients. She received her medical degree from the University of Texas Medical School, completed her general surgery residency at the University of Colorado Anschutz Medical Campus, and conducted vascular surgery research at the University of Utah. Her most important job, however, is that she has 2 children, a son and a daughter. Thank you, Dr. Kimball. Our third presenter, Kim Rozman, MSN, RN, CWOM, has been a nurse for over 20 years. She's certified wound osteotomy nurse for 9 years, worked the last 10 years in home health and hospice, completed her MSN in leadership and education in 2021, recently joined the industry with Huntley, and has a passion for wound care and ostomy education. Currently educates the value and benefits of implementing intermittent compression to improve lower extremity wound care and results. She loves to hike, mountain bike with her family in beautiful Colorado. So once again, Dr. David Yeager, I want to thank you all for attending this evening. At this point, there's our disclosures. I'm going to turn it over to our esteemed colleagues to present the presentation this evening. Thank you all.
Thank you so much, Dr. Yeager. We really appreciate it. Let me get started. I'm going to share my screen. So tonight we will be discussing why the thigh, how thigh-applied intermittent pneumatic compression can improve lower extremity wound healing. So today we are going to talk about venous leg ulcers and VLUs, the problem, and then we will move on to VLU, the health economic burden. We will then talk about IPC to improve wound healing, the hyperemic response, why the thigh, reimbursement considerations, clinical implications for reimbursement, and then we'll talk about some case studies. Dr. Johnson, I'll let you take it from here.
Thank you, Kim. Yeah, so I appreciate it. Yeah, thank everyone for being here tonight. We'll start off with like some basics on venous leg ulcerations, which is why they brought me on board. Then we got Dr. Kimball, MD, and then we have Rozman, RN. So you'll get 3 different perspectives on managing these chronic VLUs, and then Kimberly will kind of tell you about why the thigh, which is all pretty awesome stuff that they're doing in the industry. So venous leg ulcerations and chronic venous insufficiency, obviously we're kind of familiar with that, but VLUs are the most common type of leg ulcers, unfortunately, and so typically described as a shallow, moist, high exudative wound with that gaiter area of the leg that can be in the lower ankle and the foot. And typical causes here, mainly I'll just hit on is the ones that we typically see in the clinic, at least as a podiatrist, varicose veins, leg trauma. Still have one that I've been treating for about 2 to 3 years from leg trauma, surgery, sometimes the ones that we cause, or sometimes some, from car accidents or from traumatic events that occur, and also sedentary lifestyle, and then impaired calf muscle pumping, which we'll get more into as well. And then and also paralysis, typically what I see as well. So we can go to the next slide.
Sorry.
No problem. So then VLU treatment. So obviously we know the gold standard of wound therapy, initiating the assessment of these patients, typically with the venous duplex duplex ultrasound, ABIs, TBIs, because you also need to make sure that they actually have vascular flow to the area, which otherwise you're going to need both arterial and venous intervention. Often described as exudative wounds with a lot of serious drainage present, which makes it hard to heal it because of the acid pH balance that occurs, and also the bioburden that occurs. It makes it very difficult. And then compression wrapping. So luckily in my practice, we actually have occupational therapists, lymphedema therapists that actually can take care of these wounds. And also making sure you take care of the peri-wound when taking care of these patients. Quick, facts, less than 1% of your United States population will have approximately 1% would actually have a VLU in their lifetime. So it's like no pre-distant depositions, is just typically 1% of the nation. And greater than 50% of venous leg ulcers will not heal within 12 months. And I can attest to that because literally all of my patients that have VLUs have had for a while, which is why I thought this would be a great webinar when Kimberly approached us about why the thigh. And I was like, yeah, we definitely need to educate people, because either educate myself, who actually lives in this world, more on the phlebolymphedema aspects and all of that, which is awesome, because it's another tool in our tool belt that we need as podiatric surgeons and podiatrists practicing out in the field, wound care specialists practicing out. The effect of severe VLUs can be traumatic to the patients and affect their quality of life. Yeah, because they're basically living in the wound care clinic, or think about it, sometimes they're coming even on visits where we're not treating them for their lymphedema therapy, oftentimes, and then even if they have the venous leg pumps, they have to be dedicated to that as well. So it's definitely a lifestyle change. And one of the biggest keys here is the $14 billion spent per year on the United States to manage these leg ulcers, and we'll get more into that in the next slide as well.
if I can just interject,
Yeah, you
just
can.
being a home health and a hospice nurse, I've seen years and years and years of patients with venous leg ulcers, and some of them can't even control the exudate. And I've had patients with bags over their compression wraps, and it's just a really sad thing that I've just seen in their homes, and just witnessed how they've tried to manage this. And so this tool for thigh applied intermittent pneumatic compression is just kind of a game changer for these patients.
Yeah, and I'll actually jump in here. I mean, I think the fact that it's feasibility is enhanced because patients can actually deploy and use this device in their home, and we can meet them on their page where they where they're safe and secure is a huge deal. So
That's a great benefit.
Yeah, can't wait to hear more about it.
Exactly. Definitely agree. But going back to the VLU, so to expand more on that $14 billion spent per year, estimated for Medicare counts per patient is 20,000 for these VLUs. Really, it's more than that, especially if you start grafting and everything. So we are indirectly paying for that as taxpayers, which means thinking about other aspects of how we're going to treat these wounds, which involves intermittent pneumatic compression as a standard of care treatment to improve these VLU outcomes is definitely important. Then I just want to hear, before we get to the next slide, essentially have that 77% more hospitalizations than non-VLU patients for Medicare population with a VLU, and then 50% more ED visits and 27% more office visits. And that's, I mean, literally, if you probably took the stats from my clinic alone, it would probably match up to that or even higher. And it's definitely a game changer when it comes to thinking of modalities that can help with these very stubborn, hard to heal wounds. And like I tell patients, I can heal pretty much any wound. Just full disclosure, I had at one point had just stopped taking VLU patients because I was like, I cannot even get anyone healed. It was no reason for me to take them because I couldn't even get my DFU patients in. They're coming in from the ED. So at one point in my algorithms, I just excluded them, and it was almost until I got more educated on how to approach it when it came to thinking about at-home therapies and getting even home therapy nurses to help in conjunction. Because otherwise, me doing it alone, it was just impossible. So that's why I'm glad to bring this perspective. And you guys can take to the next slide.
So we have a lot of clinical evidence, and there's a recent WOCN Society endorsement on intermittent pneumatic compression. In 2022, the WOCN Society updated their their VLU algorithm, and really just stated that IPC is gaining traction. They endorsed IPC pumps for CBI, phlebolymphedema, and lymphedema in this new algorithm. And so what we're finding in practice is that some providers prescribe IPC regularly for their patients, and then some lack education on the benefits of the addition of IPC to that standard of care. We're not taking away standard of care, of course, but we're looking for IPC to optimize everything that everyone else is doing to the lower extremity. We just want to optimize, improve blood flow, and get these patients healed faster.
I think the goal is to make IPC part of the standard of care.
Yes, I would love, oh my gosh, that would be fantastic. And this thigh applied device is just a game changer in that it's pretty easy to get for your patients, and it doesn't cover over, it compresses away from the wound site, and so it's less painful for the patients. I can't wait to get to that part of the presentation.
So with regards to the actual further clinical evidence, the actual information for hyperemic response and real world prospective randomized trials are delivered here in the slide. Dr. Alvarez et al. Had a prospective randomized control parallel group comparative trial in 2020 that showed that the speed of healing was 2 times as fast in the compression plus IPC standard of care. Well, of course, patients have to fail therapy first, standard of care therapy first, before they can have IPC applied. But the goal is to get IPC as a part of the standard of care. And the IPC group, they showed 2 times as fast healing with the compression as part of the standard of care and that pain was significantly decreased in those IPC randomized patients. And then Dr. James did an open label phase 4 open label single trial prospective single center study equivalency assessment, and showed that IPC benefits a population with lymphophlebitic disease in conjunction with wound bed management, moist control, obviously standard of care guidance, and became as possible primary venous disease intervention, i.e. what I've been saying, that it could very well be incorporated into standard of care therapy, similarly to total contact cast for diabetic foot ulceration and offloading. So we all know that compression is a KPI and metric for outcomes, and this would be an adjunctive modality to supplement for that compression part of the algorithm. So to further go into a little bit of the science behind IPC, hyperemic response is really the buzzword here, and what it generates. This dates back into 1925. The external compression of the limbs with a device such as the Wound Express below diastolic pressure, venous compression, which would be those 40 millimeters of mercury pressures, elicits a short-lived hyperemic increase in velocity upon release to the inflow arteries of the limb. And it increases what we see as an arterial venous gradient, therefore allowing for that venous fluid to be moved proximally up the thigh and out of the limb, which is everybody's goal here, right? I mean, previously we use compression bandages, compression garments in the calf over the wound. It's painful for patients. Sorry, that was an alert for, sorry, apologize for that. That's been our goal, is to provide calf compression over the many years. And now we have something that is removed from the calf, allows for better quality of life and better comfort for the patient into the thigh, and elicits this amazing physiology that Morris in 2004 researched and showed that patients with full limb garments, that optimal compression and timing to produce the best hyperemic response was elicited with the use of IPC and the Wound Express device. One thing we had raised is that perhaps this device is eliciting somewhat of a compensation of inflow for patients that struggle with arterial vascular disease. And so there's so much more science to elucidate with this technology. And right now we're seeing with the research that patients have more comfort, have better outcomes, and absolutely need to be used for those that with CVI or chronic venous insufficiency, but also patients that have phlebolymphedema and lymphedema diagnosis and lipodermatosclerosis, which we'll go into those findings here in short. So again, why do we use the Wound Express, and what does it do? Well, it's applied to the thigh. It's a 3-chambered intermittent sequential thigh cuff. And the programming of this device is a duty cycle that includes full minute compression to diastolic pressures. It's a 2-hour treatment. So patients would do this in their home, and it's simply programmed to be on, off over the 2 hours to elicit that hyperemic increase in arterial and venous velocities to remove fluid and reduce and decrease limb pressures in the calf and around the soft tissue ulceration that patients would have with a chronic venous insufficiency ulcer, but also enhance and improve the outcomes for those patients that are living with chronic scarring and lymphedema symptoms in their limb.
And I just wanted to kind of pipe in here and just say that Reese Morris, who was did this study in 2020, has done many studies on intermittent pneumatic compression, both full limb and thigh applied. And he really looked for the optimal sequential compression to provide the best hyperemic response and the best compression response. And so we'll get into how the pump works, but he did find that it was about 2 minutes of compression and then 2 minutes of rest. So thank you, Dr. Kimball and Dr. Johnson. So let's talk about this thigh-applied IPC and how it works. It works by utilizing a unique and patented sequence of inflation and deflation of the three-chambered garment that Dr. Kimball had discussed. There are 60 millimeters of mercury in the three-chambered garment, and then it compresses for a 2-minute active phase, which moves the venous blood out of the thigh, like Dr. Kimball was discussing, with one of the chambers always inflated to prevent venous reflux. This creates that pressure gradient we discussed in the venous system that allows the fluid below the knee to move towards the heart, and that continues for 2 minutes. The inflation cycle then rests for 2 minutes. And this is where all the magic happens. This is where the hyperemic response occurs. That compression and then the resting causes a hyperemic, which it actually increases the velocity of the arterial and the venous blood flow down to the lower extremity. And I think that that's what makes this pump so different than any other pump out there. And it is that it's not simply just pushing fluid from distal to proximal, it's actually causing an improvement in the velocity of the blood flow. And so in this way, of course, we have the waste, the blood, and the lymphatic fluids that are moved away from the wound site, and the oxygen and the nutrient-rich arterial blood flow is increased. So this is just a little visual of the compression cycles. It's a real quick inflation deflation cycle. And this kind of gives you a visualization that one of the chambers is always inflated to prevent that venous reflux. And it's just a quick, gentle massage basically of the thigh. So why the thigh versus a full limb IPC? If you think about patients with venous leg ulcers, chronic venous insufficiency, they have these really heavy, painful limbs. And so the thigh garment, it compresses away from the wound site. And so these patients, and I can attest to seeing them when I was in home health and in the acute care, they cannot always bend over to put these large full limb garments on. And so when I was working in home health and I would go into their homes, a lot of times I would see those full limb garments just sitting in the corner, doing absolutely nothing. And so Dr. Morris and he was one of the co-creators of this device. He was interested in how a thigh applied device would garner the same results or even better, but causing the patient less pain. So yeah, we just kind of talked about this slide. It's where it's positioned, and it's it's also the decrease in pain. And so these patients are excited. They're able. It's like a blood pressure cuff that you would put on your thigh. People with dexterity issues are able to apply it, and people who cannot bend over and touch their feet are able to apply this device. I will say that the HCPCS code is an E0651, and we are going to get into that kind of in depth because it's really important. It's important to understand how to get this pump and what the reimbursement pathways are. But it is the same HCPCS code as a full limb device and the thigh applied device. So with thigh-applied IPC advantages demonstrated in our clinical studies, 95% of our ulcers improved in an 8-week period of 2 hours per day of treatment. 83% of patients experienced a reduction in their pain. It's pretty much fully covered by insurance. Sometimes there's a little bit of a copay. A lot of times the DME companies will work with the patients if they're having trouble paying the copay. And then we find that there's a higher compliance due to the thigh cuff ease of use. This is basically a screen on how you apply the garment. There are 3 steps, 4 if you include plugging it into the wall. And so you're going to place the cuff snugly around the thigh on the affected limb. You're going to attach the garment tubing to the pump. You're going to turn on the pump, and you are going to sit with your leg elevated for about 2 hours per day. And this can be an hour in the morning, an hour in the evening. The more you use this pump, the better your blood flow will be. And there really is no downside to use of the pump. And so if you fell asleep with this, say lots of our patients are in their recliner in the evening, they fall asleep, the pump is on for 5 hours, no big deal. in fact, you'll probably get a better response. So let's talk about reimbursement. This is lymphedema pumps. Lymphedema pumps are tough. They're tough for reimbursement sometimes. And so having a plan in place to make sure that you're presenting and you're presenting all of the clinical documentation correctly is very important. So like we discussed, it is the HCPCS code for thigh-applied pump is an EO651 code, and the garment is EO669. So this results in various considerations for your DME, your durable medical equipment supplier. You're going to get this through a durable medical equipment supplier, or a lot of podiatrists are their own DME, and so you would be able to bill for this pump and gain the reimbursement from Medicare. It seems that Medicare fee-for-service is much healthier reimbursement than the Medicare HMO and Advantage plans and private insurance, but you might be used to that with other products as well. So there are clinical implications for reimbursement that we're going to discuss next. So in order to get your reimbursement for this thigh-applied pump, there are two reimbursement pathways. CMS dictates all. We all know this, right? And so private insurance, Medicare Advantage, they all are dictated by the CPT code that Medicare dictates. So there is a chronic venous insufficiency pathway, and then there is a lymphedema pathway. So when you choose the chronic venous insufficiency pathway, you're covered for the treatment of CVI with a VLU in patients that have edema and affected in the lower extremity, one or more VLUs, and the ulcer has failed to heal after a 6-month trial of standard of care therapy. So if you think about it, now I took about 100 hours of my time last year, and I researched and tried to change that Medicare rule, and I was categorically denied by Medicare. But I tried, because I think it's a disservice for patients to have to try and fail 6 months of therapy before they have access to IPC.
I agree, and I'm going to interject, but that was the reason why I thought, another reason why I thought ASPS should host a talk like this, because that was the biggest reason. I was like, I need IPC to heal these patients, but if I have to do it for 6 months, that's 6 months worth of wasted time.
I know,
and
it's
that
crazy.
And that was when you brought to, I didn't even know about this until you had talked to me about it with the lymphedema pathway, which is why I invited you with it too. And it was like, yeah, so documentation matters. Dr. Kimball and Kim will get into that. And that's why I'm glad they're both here, because I know how to heal a wound and I can heal a VLU, but documentation and getting this DME reimbursed, especially because I don't have a DME license, it's tough and
it's painful. It's a painful process. I've made an EMR template that I'm going to show you at the end of this. Just to, if you can copy and paste it and put it in your notes and document against this every week or every 2 weeks that you see your patients, it's much easier for the DME company. And we have very specific lingo, and I'm learning as I go as well. I've only been doing this job for about 1.5 years, and I've learned so much. But sitting in front of the CMS, Dr. Miller, and having her explain that I didn't have enough studies that weren't powered by enough, participants in those randomized control trials to change the rules was probably expected on my part, but it was still kind of a.
But no one's putting money into VLU studies.
No. Oh, I know. Well,
I mean, at least your
that
company,
brings up Huntley. Actually, we are. Yeah, we are doing a randomized control trial right now. We have 9 centers. It's global. We have 9 centers in Europe and the UK, and we have and I am managing 5 sites here in the US. And it's been a struggle to get recruitment for these trials, even though this is kind of an easy trial to do. But we will have results at the end of this, and I think they're going to be very positive because of Alvarez's study, where in 2020. IPC heals wounds faster. You just add this modality and it heals wounds faster, twice as fast.
Twice as fast.
Yeah, sorry to interrupt, but I just have to bring that. So
if any of the fiduciaries are on this call, did you see the number? Twice as fast. That means probably half as much money needs to be spent to heal these wounds that are significant in terms of quality of life burden, supply chain burden, nursing talent burden. The list goes on about how this could be a potential saving. Yes,
definitely. So let's talk about this lymphedema pathway, because I didn't understand this until I started this job, that you can get IPC on patients with lymphedema, which includes phlebolymphedema, in your VLU population after 4 weeks of standard of care failure instead of the 6 months. I mean, this is like bing, light bulb moment. It's covered if you have, and honestly, if you have phlebolymphedema, Medicare doesn't even think that you need a VLU. You can still get IPC after failing 4 weeks of standard of care. So we know that putting on this thigh applied garment will improve blood flow. So we want to use this pump specifically is a good pump for patients with venous leg ulcers with phlebolymphedema. So let's talk about both. So this is also an extension of that previous slide. Both pathways require this documentation to prove failed trial of compression therapy. So for CVI, you need basically the compliant use of 30 to 40 millimeters of mercury at the ankle, medication list, regular exercise. And regular exercise is not that these patients are running around running marathons, of course. Sometimes regular exercise is that they got out of their recliner and they went to the bathroom, and then they went to the kitchen, and then they went back to their recliner. So if you document patient appropriate exercise, that's what Medicare is looking for. They want the patient to be using that calf pump, right, to be able to try to heal that wound as well. But a lot of these patients are limited by other comorbidities. And then elevation of the limb, and then appropriate wound care, including sharp debridement where appropriate. So and that's 6 months of that kind of documentation. But then in the lymphedema pathway, you really only need the 4 weeks of this type of documentation. And it's similar to what the CVI documentation is in terms of making sure that you're documented that the patient has used compression, that they're compliant. And you know what? Don't document non-compliance. Document against tolerance and non-tolerance. Sometimes patients can't wear 30 to 40 millimeters of mercury of compression, and we say, oh, they're non-compliant. Oh, that patient's non-compliant. I'm guilty of that too. But what we should be saying is that these patients are not intolerant due to pain and discomfort. And that's a reason for them to be able to still, that's a compliant use. If they are intolerant, it's different than being non-compliant. And then the regular exercise, elevation of the limb, and the appropriate wound care, including sharp debridement where appropriate. But when you're on this lymphedema pathway, you need to document symptoms and objective findings that establish the severity of the condition of phlebolymphedema. And this includes lipodermatosclerosis, brawny edema with fibrotic changes, stasis dermatitis, a positive Stemmer sign, and hemosiderin staining. Sometimes there's a delay. Sorry, there it is. What is phlebolymphedema? So we just touched on it, but we're going to talk about it. And we've got a fantastic picture here that really shows a severe venous leg ulcer. It shows the lipodermatosclerosis, which is that upside down champagne bottle leg shape. It shows brawny edema, which is that fibrotic skin, brawny edema, hemosiderin staining, which is kind of that orangey look to the leg. The only thing that we're missing here, and I'll get to that in a second in the next slide, is the positive Stemmer sign. We're going to talk about what that really means and why we need to document that. So phlebolymphedema, of course, is an underutilized term that indicates lower extremity swelling due to both venous insufficiency and lymphatic insufficiency. And what does this mean for the patient? It means that you can get IPC after 4 weeks of standard of care compression that doesn't progress to heal the wound instead of 6 months. And what does this mean for the clinician? This means you only have to provide 4 weeks of documentation to that DME company, or to, if you're going directly to the insurance company, per CMS guidelines under the IPC for lymphedema CMS guideline pathway. So how do you decide? So we kind of touched on that, but we're going to keep talking about it because you really have to include this in your clinical findings and in your documentation. Medicare doesn't let us just fill out a guideline. It doesn't let us fill out a one-sheeter. They want to see every week that you've documented or somewhere in the documentation that you're talking about the positive stemmer sign. So that's considered diagnostic for lymphedema. If you pinch the base of the second toe and the skin does not tent, which means it's kind of like a fat sausage toe, then you're positive. That's a positive stemmer sign. And that alone is actually a diagnostic of lymphedema. But of course, your notes can't just say one thing. You have to build this big clinical picture in order to convince CMS and the insurance companies that you need these devices. So you want to include that lipodermatosclerosis term, stasis dermatitis, hyperpigmentation, hemosiderin staining, brawny edema, fibrotic skin, and clinical documentation embedded in your notes is imperative for reimbursement. So this is an EMR template that I created, and it just talks about all of those points that CMS requires. And the DME company that I work with has us saying that the patient has been given proper wound care and used an appropriate bandaging system, exercised elevated legs for the past 6 months, and it's been determined that there's no significant improvement. The thigh-applied EO651 device is needed. We can talk about the brand of the device. There's only one thigh-applied device out there, so it is. So we do use the brand for that. But I've been trying to keep this generic for the CE education because I know that that's extremely important for us to get our CEs. And so Medicare is really big on measurements, wound measurements, ankle measurements, calf measurements, and then we have a thigh measurement because we need to apply the appropriate size cuff. And so we add that into the measurements, and then we know what size cuff to order for the patient.
Yeah, because it's good to know that the full links don't include a thigh.
Exactly. Right. There are a few cautions for use for any IPC, and that's of course if you're in if you have a DVT, if you have a PE, thrombophlebitis, and acute infections of the skin. And then if you have decompensated or severe CHF or pulmonary hypertension, you want to make sure that you're the hospitalized or your bed managed to make sure that those patients are not in acute heart failure. But patients with congestive heart failure can use this device as long as they're well medically managed. Of course, pulmonary edema, severe ischemic vascular disease, we want to have, it's up to your discretion for placing IPC on those patients. We are working on studies to show that this device will work with patients with critical limb ischemia and severe vascular disease, but right now we don't have the clinical evidence just yet, and so we want to just use this device with caution. So let's talk about a couple of case studies. These first two case studies I was able to get here in Denver. I'm based out of Denver. I met this patient, this 81-year-old patient in the hospital, at a hospital where I used to work up in North Denver. And she was an 81-year-old female that came in with a history of recurrent breast cancer, asthma, diabetes, and hypertension. She had CVI with venous edema and phlebolymphedema. And she had a history of venous leg ulcers since June. With a biopsy that was performed. And then she had a second wound on the leg from compression bandaging. And so the patient was seen at the wound clinic here in Denver. And after she was stabilized in the hospital, she came home with standard of care wound treatment that her sister performed and the thigh applied device. So this was when I met her. These were her two wounds. And we have a lot of necrotic tissue. We have a lot of slough, dirty wounds. I mean, she just did not look good. After 5 weeks of the thigh applied pump use, we're seeing lots of, much better granulation tissue. The SR is gone and we're down to just a little bit of slough, and things are, that healthy granulation tissue is starting to emerge. After 11 weeks of use, the left medial wound is nearly healed, and the left lateral is really progressing well. After 14 weeks, her left medial lower extremity wound healed, and her left lateral was progressing really well. And if you think about 14 weeks for venous leg ulcers, I mean, we're talking Dr. Johnson, Dr. Kimball know these wounds are years and years of just terrible wounds for years on end. So after 14 weeks, I know it seems, maybe that seems a little bit like slow, but in the history of these wounds, that's actually a really good result. And then at 18 weeks, both wounds were healed. And I want to say that this patient was unable to tolerate the optimal 30 millimeters of mercury of compression. And so she was just in, I want to say the brand name, and I'm not, it was in a single layer use, removable stocking for compression that just to help with a little bit, but she was not able, it didn't cause her pain. And then this was a second lady. This lady was really interesting. She was a 75-year-old patient. She had a 6-month history of bilateral lower extremity wounds, obesity, and chronic venous insufficiency. And this poor lady started with these wounds at home, and she had them for 6 months, she told me, before she decided to go to the wound clinic because she thought that she could heal them on her own. Bless her heart. And so she came in the wound clinic. We got her optimized with that 4 weeks that we have to you have to fail standard of care. So she started getting, and she had that typical lipodermatosclerosis. She had hyperkeratotic skin, stasis dermatitis. She had that positive stemmer sign. So she definitely had a clinical presentation of phlebolymphedema with CDI and severe venous leg ulcerations. After 8 weeks of standard of care, and the standard of care, there were no grafts involved in these. This was all a little bit of, I think she used a little bit of an enzymatic debrider and collagen, alginate, and two-layer compression, plus the thigh-applied device. After 8 weeks, this is what she looked like. I mean, she was really resolving, and then she was healed at 10 weeks.
And just to point out for the audience, the dermatology of progression for this case is significant. Go back one more slide.
Yeah.
You can see that this patient is suffering from significant nodular sclerosis and lipodermatosclerosis here as well, and brawny edema, which are basically, and we can't see her toes, but she probably has a stemmer sign. She definitely has a medial foot mound. But as you progress across the continuum of her care, you can really see that her skin hygiene is improved significantly. So that's kudos to the local care that she's receiving, probably from the zinc or the emollients in her double layer compression. But just in general, like she's even had clinical change of the dermatology landscape of her skin. And probably from a quality of life standpoint and a conscientious standpoint, this patient is going, wow, I could be a leg model.
Oh, right?
Right?
In our world,
and she's probably ambulatory now because the weight of the disease is reduced because of the weight, and not metaphorically speaking, but metaphorically speaking, but the true, metric weight of that disease, and of course that volume and that fluid has been moved out of the limb.
Yeah, when I first reviewed Kim's size on it, I was like, maybe she put the wrong picture in, because it's like you wouldn't even. Only thing that gives away is that you could kind of tell it's the same leg, but I mean,
same lady. I know.
Yeah.
I love that. Was one of my best clinical, and she was in this little clinic here up in North Denver. I love that little clinic, and so that was just a really great result. We have a lot of case study evaluations from the UK for this, and we have lots of small case study evaluations that have been done with the thigh applied device. We are, like I said, working on our higher level of evidence with the randomized control trial. So this was one of our case studies from the UK, from a UK evaluation, and this was very similar to my first lady's study, where she had a 5-month history of venous leg ulceration with rapid deterioration, and she was unable to tolerate static compression due to her pain, and so she wore just that one layer of a removable stocking while she employed the thigh-applied device. And you can see here that at week 16, she was completely healed. And that was a pretty devastating VLU. It wasn't small. So that was a really great outcome. And then we have a couple of Swedish studies that we did, and we had a 68-year-old female with diabetes and arterial disease. She had a mixed leg ulceration for 13 months, and after 16 weeks, she had a 91% reduction in size, and she had a pain reduction. And then our second case study there was that we had a 92-year-old male with a mixed ulceration on his medial malleolus. And after 16 weeks, we had 93% reduction in wound size. And he, of course, had a pain reduction as well. And that's something that is just a side benefit of this device that I don't know that anybody was really expecting. With a full limb device, you can have a decrease in pain to the lower extremity, but you're squeezing over that wound, and that cannot be painful. I mean, that has to be painful. And so having something that's away from the wound, but also improving the blood flow and decreasing the pain with that improvement of blood flow, I think is pretty key in this with these elderly patients for sure.
Well,
and
let's get real. Let's get real here. I mean, we're asking them to carry, layers upon layers of dressings as current standard of care, right? I mean, it's part of the CMS outcomes metrics for meeting, MIPS MACRA requirements. And then putting something else on the calf and then telling them they have to do it at home 2 hours a day is a lot. It's a lot to ask. And so moving it to the thigh only improves or reduces the risk of non-compliance with this therapy. And maybe we can actually down dose the compression layers, right?
I know it go from a 4-layer to a 2-layer, or even the tubie grip. The single layer.
single layer. Great compression.
Tubie grip, Medi grip, Spandy grip, they're all out there.
If you say them all, then you're good. Yeah. If you say them all, you're good.
So this was an interesting patient. It's a 13-month history of a venous leg ulcer, and 13 months, and it was tiny. It was tiny in comparison, 4.5 centimeters. And after 2 weeks, it healed. So this therapy really draws, I think, a lot of wounds around in this area that has the venous edema and the phlebolymphedema that's right by the wound. So sometimes the legs aren't super swollen, but there's still edema that's preventing the wounds from healing. And so if you're adding this, that's drawing that venous fluid up and away and out the body's natural pathways, you're seeing faster wound healing. And so that's what I think happened with this patient, because for 13 months, he didn't have anything. And then 2 weeks later, after using Wound Express, he was healed. This is a 9-month history of with an 82-year-old patient. And basically what they are doing a lot of times in the UK, they can't use grafts. It's too expensive. They're not grafting patients a lot in the UK. They're using alginate 2-layer wraps, maybe a little bit of collagen. And then they're, and so these patients just need that extra layer of adjunct therapy. And then this wound healed at 5 weeks of using thigh-applied. And then this was a 71-year-old female with 2.5 years of a wound to her right lateral malleolus. Again, similar standard of care was used. Her wound entirely healed after week 11, and she went into her compression stocking at week 14. So we have lots of good references for this product out there. There's lots of references on IPC in general, and then we also have great references on for those Morris studies. So if you're interested, of course, I can get you that information. And that definitely concludes our presentation on why thigh-applied intermittent pneumatic compression improves lower extremity wound healing.
Well, thank you, everyone. I just want to thank you all for taking time out. I especially want to thank our presenters. I think there was really some interesting information that presented tonight. The battle for venous leg ulcerations wages on, right? I mean, it's an ongoing struggle, especially, I dabble in wound care too as well. And as soon as we can get these healed and stay healed, the better off our patients are going to be. You know, as much as you want to see these patients and you know, heal, it's a real thing I think with these venous leg ulcerations is keeping them healed, right? And
that's
the
exactly
ongoing
right.
saga, you know.
Yeah, there's a large percentage of, I think it's 90, I want to say it's 97% of them reopen.
Correct.
And so that's a good point, Dr. Yeager. The patient gets the pump and they keep the pump. So if they should reopen, you just reapply, you know, you just start up your therapy again. It's very, it's definitely something that they can keep in their back pocket and use.
Definitely. And during the presentation, I just want to direct the audience to, on the lower portion of your screen, the Q&A portion. There was a couple questions that came in during the presentation, and please take time. I'm not going to read. Dr. Kimball was gracious enough to answer them during the presentation. So,
oh, great.
Yeah, I can read them for the committee, for the audience if you want, or
definitely
they can read on their own. It's totally up to the presenters what they would like to do.
No, I definitely think these are great questions to talk about, because
Okay.
one of them is, have these patients plateaued with multi-compression layer, or is this compression device supplementing that? They have definitely plateaued. That's what we mean when they're failing standard of care, is that it's just not getting that wound smaller and smaller and smaller each time they go see Dr. Kimball or Dr. Johnson. And so we definitely, it's definitely the adjunct that just kind of gets them over the hump to get them healed.
Yeah, you know, it's funny, when I was watching the presentation, I actually texted my wound care nurse. I'm like, hey, we got to look into this, because this is a phenomenal opportunity, because we've got those patients that are, you hit it right on the head during some of the case studies, where they're embarrassed to go out. And in fact, one lady developed and became a hoarder, and it was just extremely sad because she never wanted to leave her house.
I know.
And so those kind of, you know, stories sadden us, but with this technology and the opportunity to heal, I think this is going to be beneficial for all of our patients that are suffering from this condition.
Well, I'd love to interject to that, because part of my early years in wound management, I also was doing in-home evaluations and risk stratification for Humana. And the reason they did that is because many of their patients, I suspect, weren't going to their primary care providers regularly to actually have their annual evaluations. I was doing in-home annual physical exams, and a very large proportion of those patients that I saw had wounds. And I was like, of course, I was a wound physician, so I was like, well, I can't treat you because that's not why I'm here. But many of the times that they were like, I just don't go to my doctor because I don't even want to leave my house with this. Yep. And so it really does speak to the fact that there is such an underserved population due to the disease that live in their homes. And here you have a modality that can be rendered in the home once the provider, as I mentioned in the Q&A, can provide the ICD-10 diagnosis showing medical necessity in the documentation, per the template that Kim has so graciously provided in the talk, for patients, again, for us to meet at them on their page where they want to live and want to be, which is in their home. So right. It's just such a great modality, and it's really the reason why I've joined the group and the team, and really speak to this, because it's such an important device to implement in your VLU and lymphedema care plan.
So if we wanted to find out more information, you guys, do we just go to the Huntley webpage, or?
Yes, no, I was going to actually, I had one other slide that I was going to show that just showed, and I wasn't, but I also have, so on our Huntley webpage, we have, it's www. Let me share my screen one more time, Dana, sorry, on this side, and there it is. So I have a reimbursement guideline that you can download from Huntley on this www.huntley-healthcare.us/Wound Express website. There's a reimbursement guideline, and in that guideline, it basically creates the order for you to get this for your patients. And so if you have your staff fill it out, you can then submit that with the clinical documentation for and in those notes really say this wound has been here for 6 months. This wound, I mean, if you're just speaking to it, sometimes you hop in and the patient has had the wound for 2 years and you're the next patient, you're the next doctor to see the patient. But noting in your notes, this patient has had this wound for 3 years. I am now, now we're at this point in the care, is really important for the documentation aspect and just creating that clinical picture. And so I have a reimbursement guideline. I have this DME company that is supplying the pumps for us. And then of course you can email me, call me, text me, and I can help your office move through the process. Working with DME companies is tough. Working with getting all of the documentation precisely as Medicare wants it is tough. We do have some strategies to mitigate that. We have Parachute. There's a company called Parachute Health that has a DME platform that creates the order for you that we work with. We work with this total compression pumps, and I have somebody based out of Colorado, but we're not yet with the Byrams of the world and the bigger companies just yet. And so it's a smaller DME company, and it's just a little bit, but this woman is fantastic with total compression pumps, and so she's been getting them approved pre-auth and approved pretty quickly. We've had some denials. Some of the insurance companies don't understand. We had one insurance company woman deny it because it didn't cover the wound site. And Maureen at Total Compression got back with her and said, why on earth nowhere in Medicare's guidelines does it say it has to be on the wound or off the wound or where it just, you have to follow the Medicare guidelines, and the device works. And then we ended up overturning those denials and made them and got those pumps out to patients. It does take about 2 weeks to get the pre-auth through the insurance company once you put your order in. Sometimes that's delayed if there's a back and forth with documentation needs. And then it just takes a couple of days to get the pump shipped out to the patient from our company.
Great, thank you. There's actually 3 more comments that actually or questions came in.
Okay.
Have there been any studies with thigh compression use after the ulcerations have healed to prevent reactivism or recurrence?
Right, recidivism.
Yeah.
There have not been studies just yet. However, we know that compression prevents patients who utilize compression. It will prevent wounds, and we know that if they're using their compression stockings, goes a long way to preventing these wounds. Now, we all know that there's that comorbidity or chronic disease fatigue state that these patients get in. They stop wearing their stockings, they stop doing their compression. But if you had a patient that did this every day, some compression is better than no compression at all. We all know that adage. And so it's really, using this will go a long way, but I don't have the clinical studies just yet. It's going to keep me gainfully employed to be doing these clinical studies, all of the ones that I want to do for the duration of this device. It's a really cool device.
Awesome. Has there been any experience using IPC with any of the various grafts and or tissue adjuncts?
Yes, we have used IPC with grafts, and maybe Dr. Kimball and Dr. Johnson.
Yeah, I use IPC with grafts all the time.
Okay.
Yeah, so with the ASPS, I'll be giving basically the same lecture, but it'll be my case studies with the IPC stuff. Yeah, so they'll get to see some of the IPC's use cases with the grafts. Yeah, I still use it. I mean, some people, if they, like you said, it's kind of hard to get the thigh. If they're using the chamber one, I still have them use it. Sometimes they'll turn off the chamber that's near the site, but some of them don't have, they have the older devices where you can't control the chambers, and it still goes into the site with the full leg, and they do well. I mean, I have a lady with a BKA that has venous insufficiency on the leg, and she keeps getting venous ulcerations, and she uses it no problem, and we graft her and no issues. And then another gentleman, we graft them, heal them. But it goes back to you said, 90% recidivism where they always come back. So we call it what they call a remission clinic. So I still see them even when I get them healed with the IPC, with the graft or not, unfortunately.
So
And
that's-
I think especially with the thiopide, it's just improving the blood flow. So of course it's going to optimize the graph that you're.
Yeah, that's why the thiopide comes in a space where the compliance, right? Like maybe the issue is that maybe they went to Disney with their family or whatever they went to summer vacation to Europe and they want to bring all that big long full length IPC with them. So the thiopide is very convenient modality to still getting actually sometimes more optimal results, which you guys are finding in your preliminary data, but getting decent results with the patient. So
yeah, and I travel with this thing in a small suitcase. It wraps
so
up. It's so small. Yeah. I mean, so you can take that with you, which is what you can't do with your full length device.
So Dr. Johnson, you said that you're giving a lecture at ASPS's national conference next week in New Orleans.
Yes, sir.
Okay, at about 11:30 a.m. I mean, I don't know if people are going to be there or not.
Yeah, I'll put some fresh case studies in there.
No, that's okay. I'd like to see it again. So I just encourage everybody that's on here to fly your butt down to New Orleans
I might just have to make a cameo. I mean, that's my foot.
Dr. Kimball has a place out there. She'll be fine.
Oh, come on, Dr. Kimball, you got to go. It's next weekend. I'm going to be there. We're going to have a blast.
Let's just stay at Dr. Kimball's house.
Look, just like don't tempt her.
We have a couple more questions. Please allow us a couple of more minutes, you guys. Have you seen any blisters occur in the lower extremity with this device?
No, there hasn't been any blisters.
Okay.
Right? Yeah, and I haven't seen it in any and I'm sure they're related to IPCs. I haven't seen it blistering. I think it goes back to that, the patents that you guys have or any IPC has. They figured out the right numbers somehow.
Well, and remember, blisters are a downstream symptom of essentially a decompensated law of Laplace. So the more fluid and the more volume in that calf, the more pressure you're going to have at the skin level, reduce skin perfusion pressures, and of course skin tension goes up. And what happens? Well, you have epidermolysis, you have bulla formation. You might pinch the skin because you're obviously using external compression. And so the goals are to get that volume down so that those transcutaneous pressures go down, and therefore we'd likely see less blister formation, and that's likely why we haven't seen any. So
gotcha. And the last question is, what about patients who are wheelchair bound? I think that Dr. Johnson kind of alluded to that already. Doesn't make much of a difference, correct?
No, it doesn't. No, only question I had may help with the same question is, Kim, I had a guy actually come in. He doesn't have a wound on the foot anymore, so he's healed, but he has history of VLUs. But he had a recent hip surgery. Would you think that thiopide would be qualified? No, I guess we'll just say like IPC in general. Do you think I would be able to get him an IPC in general? Because he's closed, no VLU, but he does have stemmer sign, phlebolymphedema, and this came from the hip surgery that he had over in Canada.
If you just document, you don't have to have a wound with phlebolymphedema. So if you can document that positive stemmer sign and the venous, the venous and lymphedema, you can always try, and you send it in for pre-auth. And if he denies, then that's that. If he gets denied, then it's not great. But of course, and I've been seeing a lot on LinkedIn about orthopedic surgeries and controlling the edema in those surgeries.
That's why I was wondering about. I have them come in all the time, especially now that I'm in ortho group. They're like, "Oh yeah, Johnson knows the lower extremity," and they think I can fix their stuff. I'm like, I'm not a certified lymphedema specialist, but that's good to know. So I could get it. At least I can look like I know what I'm doing. Say, "Oh yeah, 4 weeks we can qualify."
Right.
A device.
As long as there's that positive stemmer sign, phlebolymphodema diagnosis, 4 weeks. Yeah.
Great. All right. Excuse me. I'm approaching 64 minutes here tonight. Just want to thank everyone, and especially our speakers, for taking time out. I know it's an important topic to take time away from your practices and or your families, and I just really want to extend a sincere thank you to our speakers this evening for taking time out, for our audience for taking time out, and especially ASPS and Huntley for sponsoring this fantastic presentation this evening. Look forward to seeing all of you in New Orleans next week, and working with Kim and Traci and Alton in the future regarding future webinars. So without further ado, I wish you a good night and a pleasant evening. Thank you, guys.
Thank you, everyone.
thank you. Bye-bye.